All right, in this case, welcome to tonight's Policy and Strategy panel. We're having 4 of these panels annually, and they do have some consequences. The July 2021 PSP session led to the creation of the JEDI Task Force. The January session this year on violence in the workplace led to a webinar announced on our website on de-escalation. And we are presently working on a de-escalation session with an outside speaker that will include role-playing. We do have plans for the rest of the year, which includes our health commissioner speaking on sexually transmitted diseases and the state of public health in New Jersey, etc. Now, tonight, we will hear the confessions of a reformed cardiologist, a plant-based diet for your heart, presented by Dr. Robert Ostfeld, the creator and director of cardiac wellness at Montefiore Health System, where he's director of preventive cardiology and professor of medicine at Albert Einstein Medical School. He has received a bachelor in biologic basis of behavior at University of Pennsylvania with a summa cum laude degree, and he also joined Phi Beta Kappa. He attended Yale Medical School and graduated in '96. And then he had a medical internship and residency at Mass General, a cardiology fellowship at Brigham Women's Hospital, where at the same time he obtained a master's in epidemiology from the Harvard School of Public Health. He did a fellowship in preventive medicine at Brigham and Women's Hospital, and the rest is history. His presentation will be followed by the confessions of a federally qualified health center cardiologist by Dr. Inga Robbins, who is a graduate of a Jefferson Medical College. She did internship and residency at Pennsylvania Hospital and a cardiology fellowship at Lankenau. She then spent 14 years at the Deborah Health and Lung Center, where she became the director of the medical ICU. She also was awarded the Teacher of the Year and received a top doc grade in a patient survey there. She joined Atlantic Cardiology in 2010, and the rest she'll tell you about. With that, I'll give the microphone to Dr. Ostfeld.
Well, thank you very much, and thank you for that incredibly generous introduction. And it's really an honor to be here with you all today. New Jersey is close to my heart, as I grew up there for many years in North Brunswick and East Brunswick. So it's great to be with you here tonight. So we'll be speaking about Confessions of a Reformed Cardiologist, a plant-based diet, and your heart. And I'm that reformed cardiologist. And you know, like many of you, I went through years and years of medical training and learned lots of important things about diagnosis and treatment, but I learned virtually nothing about nutrition. I kind of knew when I finished up all my training that a Mediterranean-style diet was good, but I couldn't quite define it, and that was about that. And I came down to Montefiore to start to do all the things that I was trained to do, guideline-based medications, procedures, all that. And people were getting a little better, but they didn't get a heck of a lot better. And I didn't go into medicine for people to get a little bit better. I wanted real transformational change. So I was really starting to get disillusioned. And it was right around that time that I learned about the impact of a plant-based diet on cardiovascular and overall health. And one thing led to another, and started our cardiac wellness program at Montefiore with the goal of preventing disease with a plant-based diet. And honestly, outside of a medical emergency, like somebody gets shot and has to be put back together again, I've never seen anything come close to the breadth and depth of benefits that a plant-based diet provides. So let's see my next slide. These are my disclosures. And so I'll start with a piece of a case. We started our program maybe 2009 or so, but this is a case that we published that we saw early on that helped me realize that we were on, I think, a pretty good path. And so there was a 60-year-old gentleman. He was starting to have chest pressure, and sometimes he'd get even sitting still or walking a little bit. And he saw his primary care doc where they did a stress test, and the stress test was positive. And obviously, it's only in medicine where the word positive means something bad. And it was in that milieu that he came to see us. And this is how he was. You could see he was a little overweight. His blood pressure was a little high. His LDL cholesterol was pretty high. And on average, he could walk 1 to 3 blocks, and he'd stop because of chest discomfort. And he had told his primary care doc, and he reiterated to us that he was not interested in any medications, nothing. He wouldn't take an aspirin. He wouldn't take a statin. He was not interested in any procedures, no cath, no nothing. And of course, that, we want all the above to protect people, medications, lifestyle, procedures when necessary. But at the end of the day, an informed patient is the boss, and that was his decision. So all we had left was lifestyle change for this person. And what he did is he started a plant-based diet. So consuming smartly or minimally processed plant-based foods. So tons of vegetables, fruits, whole grains, beans, lentils, tofu, yams, nuts, and seeds, avoiding all animal products and all junk food. And so what we're going to do is we'll circle back in a little while to see how he did. And from a big picture perspective, as you all well know, cardiovascular disease is the #1 killer of adult men and adult women in the US. Women are about 6 to 7 times more likely to die from cardiovascular disease than they are from breast cancer. Now, clearly, you do not want either one, but it highlights the epidemiologic importance of cardiovascular disease in women. About 2 heart attacks happen every minute in the US. So I don't know, maybe we've been on this for a call for 10 minutes, so that's 20 heart attacks. And it's, of course, a very expensive disease process. And I just put this slide in. And now, how do we get? Now, atherosclerosis or cardiovascular disease starts when we're very young. And there's data, pathology data, that approximately 60% of 12 to 14-year-olds have very early signs of atherosclerosis on autopsy studies of kids who died for other reasons. So this is a disease process that starts when we're very young. And there are, of course, those famous pathology studies of Vietnam and Korean War veterans, where the US soldiers who, they're in the prime of their life, 19, 20, 21 years of age, and fully, depending on the study, somewhere between 45 and 75% or so of them have overt coronary artery disease. So how do we get from where we want to be, a healthy artery, to where we don't want to be? So this is a cartoon picture, of course, and this is an artery, the center of the artery. These are the little cholesterol particles, and the endothelial cells, which line the inner wall of the artery like wallpaper, can become sick and injured, whether that's from a toxic Western diet, inflammation, pollution. And when that happens, these cholesterol particles can then burrow across the endothelial cell into the wall of the artery, where they may become oxidized and irritating like a splinter. And when that happens, there's more inflammation here, more oxidative stress. The endothelial cells get sicker and sicker, more cholesterol particles burrow across, and the plaque grows and grows, and the artery subtly becomes less healthful. And this little white line develops here. That's called the fibrous cap. Who cares? Well, that's the only thing between this the center of the artery where the blood flows and the cholesterol in the wall of the artery. And over time, as there's more inflammation, more oxidative stress, this fibrous cap gets thinner and thinner and weaker, so one random Tuesday afternoon, it can crack, like here, exposing the atherosclerotic plaque to the blood, possibly clotting it off, here blocking it off, all the way causing an ST elevation myocardial infarction. And of course, this is a medical emergency. You want to stent right away. But of course, we want to prevent going from here to there. Now, flipping back to nutrition, which suboptimal nutrition is the leading cause of cardiovascular disease in the Western world. And I thought we could embrace the scope of the nutrition problem in the US. So this is a wonderful analysis of the NHANES database of about 12,000 people, a representative sample of the US. And these investigators created a, quote, healthy diet score. And they defined it with 5 elements. And the first one was having at least 4.5 servings of fruits and vegetables a day. That's one. At least 3 servings of whole grains a day. Low sugar sweetened beverage consumption, low salt consumption, and fatty fish consumption at least twice a week. And if you had 0 or 1 of those 5, you had a poor diet score. 2 to 3 intermediate, and 4 to 5 was considered ideal. So fully 75% of the US had a poor dietary pattern. 25% have an intermediate, and 0.7% of the US had an ideal dietary pattern. This is, of course, a crisis. There is a giant gap between where we are and where we could be. But does it even really matter? Well, of course it does. These same investigators estimated if everyone in the US adopted a, quote, ideal diet for 1 year, cardiovascular event rates would fall by about 42%. Find me a medication that does that in a year. So we're going to talk through the impact of a plant-based diet on cardiovascular health. We're going to touch on cholesterol, inflammation, hypertension, weight, diabetes, novel risk factors, quality of life, mortality, and then if there's time, jump off on a handful of other projects or topics, including what we're doing more specifically at Montefiore. So cardiovascular health. Now, this is a great study from the CARDIA database, the Coronary Artery Risk Development in Young Adults database. This is a plant-centered diet and risk of incident cardiovascular disease during young to middle adulthood. And in this analysis, they looked at about 5,000 subjects, 18 to 30 years of age, free of known cardiovascular disease. And they put people, this is a prospective cohort, and they put people into quintiles of plant-based diet. And the highest versus lowest quintile had a 52% lower hazard of incident cardiovascular disease over 32 years. And of course, just like our patient had a smartly or minimally processed plant-based diet, when we're talking about that, you could be plant-based and eat sugar cookies all day, or you could be plant-based and eat kale all day. So the devil's really in the details. And this study by Satija, a wonderful study, gets to that. And this looks at the Nurses Health Study 1, Nurses Health Study 2. And if you look here, this blue dotted line, that's if you ate, I'm sorry, I should say there's about 4.8 million person years of follow-up here. If you follow me for 1 year in a study, that's 1 person year of follow-up. So a lot of person years. So if you eat more of a plant-based diet overall, you did better. Okay. But what about the details? So if you ate an unhealthy plant-based diet, the sugar cookies, you did worse. But if you ate a healthy plant-based diet, the red line, you did even better. So the devil's in the details. And accordingly, we, of course, want to get rid of the junk food. This is a fascinating study out of the Journal of the American College of Cardiology, where they looked at the Framingham cohort and found, not surprisingly, that if you ate more ultra-processed junk food, pictured here, you had worse cardiovascular outcomes. There was a 7% worse with each serving. Okay. But that's not surprising. But to me, what was particularly shocking about this study is that the average participant had 7.5 servings of ultra-processed food every day. It's like, what else do you have time to do? And along the lines of, minimally or smartly processed, when we're talking about grains, we're talking about whole grains pictured here, not the white bread or white flour. And in a wonderful meta-analysis with 135 million person years of follow-up by Dr. Reynolds, found that eating more whole grains was associated with less diabetes, less colon cancer, fewer cardiovascular events? How about more fresh fruit and cardiovascular disease? In this wonderful analysis by Dr. Du, asking if you ate more fresh fruit, is it associated with improved or not improved outcomes? So here, eating more fresh fruit was associated with less cardiovascular disease, fewer cardiac events, less stroke. Oh, and I put this busy slide in here because the question I frequently get is, hey, doc, heart disease, it runs in my family. So I'm going to get it. Well, genes matter, of course, but lifestyle matters too. And let's just focus on this part down here. Now, what they did in this analysis is they made a genetic risk score. They looked at about 26 different genes, each individually associated with a little bit more cardiovascular risk. And they followed 3 cohorts prospectively. And so they took a high genetic risk group. And what I thought was particularly interesting in this study is that if you have a higher genetic risk, yeah, you have a higher cardiovascular risk than low genetic risk, like shocker. But what they did also is they split people into lifestyle, an unfavorable, an intermediate lifestyle, and a favorable lifestyle. And even within the high genetic risk group, if you went from an unfavorable lifestyle to a favorable lifestyle, you lower your future risk of cardiovascular events by about 50%. So genes matter, but so does lifestyle. How did you get into the favorable lifestyle group here? Well, you had to exercise at least once a week, and you had to have 50% of your diet from a group of healthy foods. Imagine if you exercise 4 times a week and your diet was 75% from those healthy foods. You would imagine you would lower your risk of a cardiac event even more. Okay, we talked a bit about a plant-based diet and cardiovascular health. How about cholesterol, inflammation, hypertension, risk factors? So in this wonderful analysis by Dr. Jenkins, where they compared a dietary portfolio of cholesterol-lowering foods, which in this case is a high-fiber plant-based diet with a statin, in this case, lovastatin 20 milligrams in hypercholesterolemic patients. And it's a crossover study, 34 people. The control arm had, they lowered their LDL about 9%. The statin, about 33%, and the portfolio diet, about 30%, almost equivalent to the lovastatin arm. And of course, we don't look at it as either or, we look at it as all of the above to protect someone. Another great study of the same diet by Dr. Jenkins, and they randomized people into one of 3 arms for 6 months looking at LDL cholesterol. And they found the low saturated fat diet lowered it about 8, but the portfolio diet, whether they saw people a lot, or a little, of course, the high fiber plant-based diet lowered LDL cholesterol considerably more. But all right, so what? Does that improve anything? Well, if investigators looking at the Nurses' Health Study, Nurses' Health Study 2, and Physicians' Health Study with up to 30 years of follow-up, created a portfolio diet score. They looked at the highest versus lowest quintile of it, and the highest versus lowest quintile had a 14% lower hazard of cardiovascular disease. And with a 25% increase in the portfolio diet, it lowered your hazard by about 8%. Some of you may have heard about this study or saw it on, I think it was Netflix. This is Dr. Gardner's study out of Stanford, where he took omnivorous and vegan, he took identical twins, 44 people total, and randomized them to omnivorous or vegan diets, eliminating the genetic difference. And the primary outcome was LDL cholesterol, and they found that the vegan diet lowered LDL cholesterol significantly more than an omnivorous diet. How about cholesterol and inflammation? Well, we talked about how when the LDL particle crosses the endothelial cell and lands in the vessel wall, it can become oxidized and irritating like a splinter. In a test tube study, they took LDL particles from omnivores and matched them with vegetarians, and found that the LDL particles of vegetarians were significantly more difficult to oxidize in the test tube setting than omnivorous people. CRP, of course, is a blood test of inflammation, and inflammation promotes all aspects of atherosclerosis. And as you may have seen, colchicine is now being, considered for people with chronic and acute coronary syndromes, as it may reduce the residual risk present with inflammation in those subjects. Now, from a dietary perspective, there's a wonderful study out of NYU called EVADE-CAD. And in EVADE-CAD, they took 100 subjects with stable coronary disease and randomized them to the American Heart Association diet or to a plant-based diet. And the primary outcome was CRP. And they found that after 8 weeks, CRP fell significantly more on the plant-based diet than it did on the animal or the AHA diet. What about hypertension? Well, whenever I read this statistic, I have to reread it because it blows my mind. If you're a 45-year-old adult in the US, your lifetime risk of developing high blood pressure is somewhere around 85%. I mean, it's crazy. And if you look at the C-MONA people, you may have heard of them. There was a wonderful study out of Lancet describing them in 2017. And they're an indigenous population that live in the jungles of Bolivia. And they have subsistence living. They're very physically active. Their diet is about 72% complex carbs, 14% fat, 14% protein. They have, and in this analysis of those 45 years and older, 5% of them had high blood pressure. So it appears high blood pressure really is not a fait accompli. And if you looked at just the group that were 75 to 94 in this analysis, 8% of them had high blood pressure. So we're doing something not so great. And you may remember stories about Walter Kepner. He made the rice diet out of Duke, like in the 1930s, 1940s. And he's got some interesting case series. There's interesting articles about the stories around his diet. But at the time, there really was no treatment for high blood pressure, and malignant hypertension had something like a 50% 6-month mortality. So he has a case series of about 190 patients that he put on a rice and fruit diet. 25% of them died. Of the remaining 167, and remember, this is like a 50% 6-month mortality, 107 of them improved their blood pressure from 200 over 112 to 149 over 96, when there really was no therapy for high blood pressure back then. And about 73 of 82, where they had data, lowered their cholesterol. So an interesting proof of principle. Back to the Cardia data set, here with about 4,000 people and 15 years of follow-up, the highest versus lowest quintile of a plant-based diet had about a 36% lower hazard of incident hypertension. And of course, you're very familiar with the DASH diet, the Dietary Approach to Stop Hypertension diet studies. There's been any number of them, which is primarily, but not exclusively, a plant-based diet. And compared to more omnivorous or Western-style dietary patterns, it significantly lowers systolic and diastolic blood pressure. But does it really matter? Well, of course, we believe it does. And in this interesting analysis out of New England Journal of Medicine, they created a DASH diet score, and they found that a 13 to 30% increase versus almost no increase in the DASH dietary score was associated with about 11% lower hazard of mortality. So we talked about how a plant-based diet may improve cardiovascular health, how it may, particularly a high-fiber plant-based diet, may lower cholesterol, can improve inflammation, lower blood pressure. What about weight? So there is some data there as well. Now, this is the Seventh-day Adventist study. And the Seventh-day Adventists, of course, are a religious organization. They treat their bodies like temples. In this analysis of about 60,000 people, there were enough dietary patterns that they could break them up. And so there are vegans, lacto-ovo-vegetarians, pesco-vegetarians, semi-vegetarians, and non-vegetarians. And the Seventh-day Adventists, even those who eat a Western-style diet, eat a much more healthful version than the typical Westerner. And you can see in this cross-sectional analysis of about 60,000 people, the only group with a quote normal BMI was the vegans. And in a very interesting randomized trial by Dr. Turner McGreevy out of the University of South Carolina, they did a 6-month randomized trial. It's small, but these are hard to do, of different dietary patterns and weight loss. And they found that the vegans lost about 7.5% of their weight, which was significantly more than pesco-vegetarians, semi-vegetarians, and omnivores, but not significantly more than vegetarians. Okay, so we talked about the impact of a plant-based diet on cardiovascular health, on cholesterol, on inflammation, blood pressure, weight. What about diabetes? This same Seventh-day Adventist study found that the group with the lowest percentage numerically with diabetes was the vegans. And in this analysis of a plant-based dietary pattern and incidence of type 2 diabetes from 3 US prospective cohorts, Nurses Health Study 1, Nurses Health Study 2, Physicians Health Study, with about 4 million person years of follow-up, they put people into deciles of a healthy plant-based diet and an unhealthy plant-based diet. And the highest versus lowest decile of a healthy plant-based diet is associated with a 34% lower hazard of incident diabetes, type 2. But just as we talked about the devil's in the details, you could eat sugar cookies all day and be plant-based. The highest versus lowest decile of an unhealthy plant-based diet is associated with I think it's 16% lower hazard, or excuse me, increased hazard of incident diabetes. I say I think because I've got like the Zoom bar across the screen at the bottom. I can't read it exactly. This is a fascinating randomized trial by Dr. Barnard's group, the Physicians Committee for Responsible Medicine. And they took people with type 2 diabetes, 99 of them, and randomized them to a plant-based diet or the American Diabetes Association diet for 22 weeks. And those in the American Diabetes, those with the plant-based diet lost significantly more weight, and their LDL cholesterol fell significantly more. If you look at diabetes outcomes by A1C, for those who had no medication changes, hemoglobin A1C fell significantly more in the plant-based diet. But overall, I'm just going to try to move this bar. There we go. Overall, because some people had to have medications backed off because they were getting healthier, A1C fell numerically more, but not significantly more in the plant-based diet. So I'm also getting a little tired of hearing how fruit causes diabetes. This interesting analysis from Dr. Du, about 480,000 patients, that same data set out of China, asked if you eat more fresh fruit, is that worse? Is it not worse? Well, the more fresh fruit you ate, the less incident diabetes. What about if you had diabetes at the get-go? 30,000 people had diabetes at the get-go. And if you ate more fresh fruit, that was associated with lower all-cause mortality, as well as a variety of improved outcomes like renal and ocular that, of course, are of concern with diabetes. So we talked about the impact of a plant-based diet on cardiovascular health, on cholesterol, inflammation, high blood pressure, weight, diabetes. What about some novel risk factors and quality of life? Well, there's an interesting study of early stage prostate cancer from some years ago. And they took people and they put them on a healthy lifestyle pattern, which included a plant-based diet, regular exercise, psychosocial support. And these 30 guys, they biopsied their prostate before and about 3 months after. And they found that many pro-cancer genes, after those 3 months, were down-regulating their expression, and many anti-cancer genes were upregulated. So it's interesting. We can't change our genes, but we may be able to change which ones speak. A healthier lifestyle making them speak more loudly, the healthy ones speak more loudly, and the adverse ones speak more softly. It's pretty cool. And of course, the microbiome is getting a lot of attention now, in terms of its ability to make short-chain fatty acids that have antioxidant, anti-inflammatory effects, may have a multitude of physiologic effects in the body and brain, which I guess is part of the body. So eating a more high fiber plant-based diet is associated with improving the microbiome population, but this is, of course, early days. And actually, I think Rutgers University has one of the world's leaders in microbiome research. What about quality of life? Well, this is changes in plant-based diet quality and health-related quality of life in women. And this is an increase in the healthy plant-based diet index was associated with improvements in physical and mental health-related quality of life in women, as defined via these SF-36 score. So we talked about the impact of a plant-based diet on cardiovascular health, on cholesterol, inflammation, hypertension, weight, diabetes, novel risk factors, quality of life. What about mortality? Well, in this fascinating cohort study, they looked at fruit and vegetable intake and mortality. They looked at both 2 prospective cohorts and 26 cohorts from across the globe. And in the 2 US cohorts, 5 versus 2 servings a day was associated with a 13% lower hazard of death. But when they did the same analysis, 5 versus 2, in 26 cohorts across the globe, they found the same 13% reduction, remarkably consistent. And in this degree of adherence to a plant-based diet in total and cause-specific mortality, the prospective cohort study in the Million Veteran Program with, curiously, 300,000 people in this analysis, but they put people into deciles. And they followed them for 4 years, and the highest versus lowest decile of plant-based diet was associated with a 36% lower hazard of mortality, and an unhealthy plant-based diet was associated with an increased hazard of mortality. And looking here, you don't have to have anyone's sense of perfection be the enemy of good. Every little bit counts. And in this analysis of subjects with at least one cardiovascular risk factor, they replaced just 3% of their calories from animal-based protein with 3% of calories from plant-based protein. And they asked, is it good? Is it not good? Well, it turns out it was good. And if you look here, they had so much data, they could break it down by type of protein. So processed red meat, if you replace just 3% of your calories from processed red meat with 3% of calories from plant-based protein, that's associated in this analysis with a 34% lower hazard of death, unprocessed 12, poultry 6, fish 6, eggs 19, dairy 8%, all significant. Oh yeah, so just breaking it down a little bit, there's some popular dietary patterns which we could get into more in the Q&A, but I thought it would be interesting to look at a nutrient breakdown of a plant-based diet, Mediterranean, and a low-carb diet per 500 calories. And how did I define it? A plant-based diet is equal parts tomato, spinach, lima bean, peas, and potatoes. A Mediterranean-style diet is 40%, sorry, I just got to move this thing, 40% of what was in the plant-based diet, plus a half a piece of skinless chicken, 1 teaspoon of olive oil, and 1 cup of 1% milk. And the low carb is equal parts beef, pork, chicken, and whole milk. All right, let's see. Cholesterol. You don't need to make a drop. Your body makes all you need. What about protein? Oh my God, my muscles are going to fall apart tomorrow. The low carb arm with beef, pork, chicken, and whole milk, the same. Now, you don't have to take my word for it being the same. You could take Patrick Baboumian's word. Patrick Baboumian is the world's strongest man. How do I know that? Because he won the world's strongest man contest. That's how I know. And Patrick Baboumian is vegan, plant-based. How about beta carotene? It's subtle, fiber, your constipation will go away. All these nutrients line up favorably in the plant-based arm. Is that aligned with guidelines? Indeed. The American College of Cardiology primary prevention guidelines support a diet emphasizing vegetables, fruits, legumes, nuts, whole grains, and fish to decrease atherosclerotic cardiovascular risk. They also support a wholly plant-based diet. The American Society for Preventive Cardiology recommends a similar dietary pattern, largely plant-based with some fish. The European guidelines also recommend the Mediterranean or similar dietary pattern to reduce cardiovascular risk. They're all aligned at primarily plant-based diet. So let's circle back to our guy, our 60-year-old patient who didn't want to take meds and was having chest pain, walking just a few blocks and went plant-based. Okay, you can see after about 3-4 months, he lost weight, blood pressure normalized, LDL fell a lot. He could walk about a mile and he'd stop because of chest discomfort. Fast forward about a year, and you can see as it was normal weight, blood pressure still normal, LDL still low. He could jog about 2 miles then. And I bumped into him about 5 years ago before the pandemic. And he was jogging about 4 miles and he stopped because he got bored. So this is a great quote. Today, no one can deny the possibility of adequate nutrition and the prolonged maintenance of health and vigor on a vegetarian diet. That's from JAMA in 1912, before the term vegan was even coined. So far, we talked about the impact of a plant-based diet on cardiovascular health, cholesterol, inflammation, high blood pressure, weight, diabetes, novel risk factor like genes and microbiome, quality of life defined by the SF-36 score, and mortality, the 5 versus 2 prospective cohort, for example. Dr. Kim Williams, the past president of the American College of Cardiology, says, I recommend a plant-based diet because I know it's going to lower their blood pressure, improve their insulin sensitivity, and decrease their cholesterol. I think I have a few minutes and I can dive a bit into erectile dysfunction. And you can tell me if I'm running over. The reason I bring this up, the definition of it is the inability to achieve or maintain an erection satisfactory for sexual performance. What causes it? Most commonly in the Western world, it's vascular or atherogenic. Of course, there are other causes as well. It's extremely common. This is a study out of 1994 looking at how common it is, but I believe it's more common than this because people don't like to talk about it. People are a little embarrassed about it. And we also call it the canary in the coal mine for heart disease because it typically presents about 2 to 3 years before angina and 3 to 5 years before cardiovascular events. Why might that be? Well, the artery to the penis is smaller than the artery to the heart. And by the time you have a cholesterol blockage in the artery to the penis, causing erectile dysfunction, it's very likely, because atherosclerosis is a systemic disease, that you also have cholesterol disease in the blood vessels that feed your heart with blood, but just have yet to clinically manifest. And it does matter. In a prospective cohort of about 1,900 people, ED is associated with a 40% greater hazard of mortality versus no ED. So it's common. It's the canary in the coal mine for heart disease. It has overlapping risk factors, of course, with cardiovascular disease. Randomized controlled trials of a Mediterranean-style dietary pattern and other lifestyle change show that doing that can improve erectile function. We also presented a case at the American Society of Preventive Cardiology of a plant-based diet reversing erectile dysfunction in a patient. It may prove, that reversal may prove uniquely motivating. And as part of our cardiac wellness program, we have a couple of randomized trials going on now looking at the impact of dietary pattern on erectile function in young, healthy men with normal erectile function, which I could talk about a little bit more. This is my dog, Toshi. And Toshi is here to remind me that yes, a healthy diet's important, but it's part of a larger lifestyle pattern, healthy lifestyle overall, exercise, healthy diet, healthy sleep, of course, screening for sleep apnea, not smoking, normal blood pressure, low cholesterol, normal weight. Took me a little while to figure out what this Subway looking thing is, but it's low sugar as well. So this is the American College of Cardiology meeting for cardiologists. So we clearly have a long way to go. Because I'm like, honestly, nobody's taking the stairs at the American College of Cardiology meeting. I'm like, this is ridiculous. I have to take a picture of it. And it turns out that later I realized that one of my co-fellows was on the escalator, so I got to make fun of him later. But so this is the Bronx. This is where Montefiore is based, very close to New Jersey, where I grew up. And I have family up around here now. And this is where our wellness program works or lives. And we've got a clinical arm, a research arm, an educational arm. And our clinical arm has an inpatient and outpatient component. And our inpatient component, which may be of interest here, we wrote an article about it in the International Journal of Disease Reversal and Prevention, how we developed plant-based meals for inpatients. And we put the documentary film Forks Over Knives with Spanish subtitles on the inpatient TVs that you can watch. It's on one of the inpatient educational channels that you can watch for free for inpatients to help reinforce educating about plant-based diets, because nobody has time. And that article we wrote was really meant to be a how-to for it. And you may be familiar that health and hospital systems throughout New York City, spearheaded by the mayor, Eric Adams, I know has had some issues of late. And of course, unrelated to that, Dr. Michelle McMacken and her incredible plant-based nutrition work, running the medical aspect of the program, they've implemented plant-based diets as a default diet throughout the health and hospital system in New York City, which is wonderful. And they recently published an article in the American Journal of Lifestyle Medicine where they found that they decreased their carbon footprint by about 36% with these meals. And each tray of food costs something like, I forget, 59 cents less than if it had animal products, which adds up. And the article gets into more detail. And of course, on a societal level, an analysis from the UK, modeling study out of the UK and Belgium found that if people ate more plant-based nutrition, they'd save billions of dollars with the B. And of course, animal agribusiness, from a planetary health perspective, animal agribusiness creates more greenhouse gases than all transportation combined, which includes cars. And who really cares how healthy you are? No planet, no health. So that's obviously critically important. So what to do? What to do? So what I suggest is that we don't let perfection be the enemy of good. Every step in a more healthful plant-based direction counts. We are woefully far from that. So I just focus on the 0.7%. 0.7% of the US consumes an ideal dietary pattern. People scream and yell and fight about the greatest diet of all time ever. Total waste of time. We're not even within 50 miles of that. Every step in the right direction matters. We made a cardio nutrition podcast. This is me on social media. But we made a cardio nutrition podcast with the American College of Cardiology some years ago with about 20 bite-sized episodes if you're interested in hearing more about different dietary patterns. And so it's really a great honor for me to be here with you today. New Jersey is always close to my heart. In fact, I was there just this past weekend. So thank you very much.
Thank you, Dr. Ostfeld. We have to seriously consider what we can do to improve individual health as much as public health. Now, in order to select food, you've got to have food to begin with. And I think this is some of the issues that Dr. Robbins will address. Dr. Robbins, please.
Yeah. So I know Josh is going to be bringing up my slides. So I'm going to talk a little bit. I don't know if I'm a reformed cardiologist or just a cardiologist who's kind of tired of seeing all the complications that we see day in and day out due to upstream issues. So I think that this is really I'm going to talk a little bit about my story, but really this is our story. This is the story of every physician, everyone on the healthcare team who is seeing these devastating peripheral vascular, cardiovascular, and even malignancy stories that we're seeing. And on top of that, we're seeing a lack of equity in this story. And so this is so you can go the next slide and talk a little bit about how back in 1995 I came out of cardiology fellowship, and I was all excited about doing all these really cool procedures. And so I went to this awesome place called the Bora Heart and Lung Center, where it is a charity hospital and provides a lot of access to that. So like, how did I start getting involved in advocacy? How did I end up getting involved in Medical Society in New Jersey, become a member of the JEDI Task Force, Climate Task Force, and the Obesity Task Force, which are all aligned with each other, get involved in my specialty society, advocacy committee. How did all this happen? Well, essentially, I eventually got closer to the actual urban community where I had always dreamed of working, and began to work in a federally qualified healthcare center, which is basically a community health center that is serving safety net patients. And so one of the things, as I counseled my patients who, huge disparities in cardiovascular health, that we're seeing patients who, based on their geography, there are huge differences in longevity. And so I'm starting to feel like, wow, I'm trying to counsel them on healthy diet. And, am I just making them feel bad because they can't actually get these foods? And so I ended up partnering with an awesome social work professor at Stockton University, our neighbor, and we did a focus group study on our population, our federally qualified healthcare patients. And so we used Dr. Kersner used in vivo software to generate really like an analysis of everything that these people said. And so you can see that in this graphic distribution, the apple that we're looking at now, the size of the words is basically showing how many times these different themes were brought up. So I put a link in there to the article. And so I started to think about, how are we going to bring this food to these populations? And we tried actually group support programs, but the reimbursement is a challenge. Diabetes prevention program, DPP, is another thing that we've tried to bring, but there's some financial hurdles that you have to get over. And so our health center is constantly handing out vegetables, fruits, but it really is in some ways still a drop in the bucket. So you can go next slide. So this is what we're facing right here. And you can see that even though Atlantic City is _2 in all of New Jersey, we can see that there's really no place in New Jersey where there are not these epicenters of disparity, these food deserts. And so go ahead to the next slide. And so, yeah, so what is nutrition security really? And so the USDA defines this as having equitable access to foods that are essential for optimal health and well-being. And so if we're talking about 13% of all households across the United States being nutrition insecure. We can only imagine the percentage of people who in these epicenters, these food deserts, are insecure to healthy foods. And you can see that this is a great reference I got from Dr. Lake from the Lori Tisch Center for Food Education and Policy. Next slide. Okay, so here's the blueberries versus blueberry Pop-Tarts. So, and this is from a nutrition magazine. I actually really like this article, but where they're saying that people who have food insecurity tend to maximize calories per dollar. So this is very real. I've seen people talk about this all the time. People feel that they have to get calories into their body, even though a lot of these high glycemic index foods are only making these people hungrier and not really providing any nutrition. Next slide. So yeah, so this is the food swamp here. So the other day, one of our nephrologists providing care at our health center, he's been trying to lose weight. He's been trying very hard to eat healthy, studying healthy diet, but he had not packed his lunch, and he ended up having lunch at Popeye's Chicken just across the way. And so this is lunch in the food swamp. And unfortunately for our patients, for many of them who have transportation barriers, the only thing they're really getting is what's in the swamp. And you can see here that Dr. Camille Green, who is also another awesome member of the JEDI Task Force, has provided this same reference that we saw Dr. Ostfeld providing earlier on about the Framingham study. So this is what we're talking about. We're talking about these ultra-processed foods, the sugar cookie theme that Dr. Ostfeld brought up. And this is where we have to ask ourselves, where does our food system really come into this whole picture? So by providing these kinds of high glycemic foods, people are caused to eat 50% more because of the insulin rush that they get. And obviously that means that more cheaply produced food can be sold. Next slide. Okay, so again, my story is really not unique. I have just been lucky to have some mentorship so that I've been able to get involved in mentorship activities, which were hugely resilience building. So this is something, it's just an excerpt from an article. This is something we see every day, is that not only are people living in a food desert with poor transportation off what we in Atlantic City call the island, because again, Atlantic City is an island. But on top of that, there's so much going on in their lives. They're hearing gunshots, they're being evicted, they're having family issues. So just that whole executive planning of meals, all of this is really a problem when you're stuck in a food desert. And then, when we as physicians become more aware of the various social determinants of health, but don't have any opportunity to take action on them, it is just basically causing more burnout. So what do we do about that? Well, I think that this is something that affects all of us. I think that people should definitely We definitely want everybody's input on Dr. Ostfeld's presentation. We want input on these issues here. Get ready to ask questions and participate in our discussion. Next slide. So really, again, the frustrations are very real, but it's in partnership that we find resilience. I want to really of different wonderful organizations. I want to just highlight and put a spotlight on the Medical Society of New Jersey JEDI Task Force, led by Dr. Bob Like and Dr. Camille Green. I've included the mission statement here. This is a very thoughtful team of dedicated people, where we can share our concerns, where we can move forward and create education. And in our connection with Medical Society of New Jersey, we can also move towards education of our community, but advocacy as well. And I will say that these teams are incredibly welcoming. I mean, you don't have to be someone who starts experienced in advocacy, whether it is getting involved in Medical Society, New Jersey advocacy, etc. It is really about a welcoming situation and an opportunity to engage is what I've really experienced. Next slide. So what are some of the things that we're exploring to address this? So here again, Dr. Like, Dr. Green have provided some of this information, and this is actually a slide that did come out in the American College of Cardiology, so with which we're familiar. And so here we're talking about some of these plant-based foods that were discussed before, and we're talking about different means of tailoring foods to patients' health conditions. And then we're talking about the importance of partnerships with community-based organizations, federal, local programs, medical nutrition, etc. So again, this becomes a team approach, and our organized medicine is very good at interfacing, and certainly Josh is already talking about some connections that we can form with the food system in New Jersey. Okay, so next slide. Okay, so evaluating solutions, we have to be very thoughtful. That this is why we have to have experts of all different expertise collaborating to understand what's going to be sustainable financially and environmentally. Are we going to give everybody write a prescription for the patient to have this food delivered to their home, or is there also an important role for education? Do we need to address our food system? Do we need to ask ourselves, how is our food system contributing to the obesity epidemic that we are experiencing? And how do we thoughtfully consider equity? How do we consider these meals being culturally appropriate? We have in Atlantic City the 10th highest, even though we're a very small city, the 10th highest Bengali population in the nation. And how do we get input from our communities? So these are all the thought processes that teams can bring to the table. And remembering that as physicians, our voices really are important. And you'll be surprised, because as a physician, sometimes, you feel like you're being told to keep your head down and do what they tell you. But actually, when you do raise your voice, it makes a big difference. Next slide. Okay, so here again is something that Dr. Ostfeld brought up. And so this is another flip side of this picture, is that as we're eating foods that contain beef, lamb, and then the climate effects are very significant. And if you look at 35.5 as a measure of greenhouse gas emissions from beef compared to 0.3 from nuts, it's pretty remarkable. And we're realizing that the other downside of a diet that is very high in animal foods, particularly red meats, is that these environmental impacts we know also are going to affect those communities that we call environmental justice communities. And there's a similar map of that in New Jersey. They're going to be hit the hardest by this. They are going to experience the heat islands and everything else. Next slide. Okay, so what are some kind of like, how do you actually create structure around this advocacy piece? So this was shared again by Dr. Like here, and this is a bill that's been brought forward, basically talking about organically grown food and getting it into the hands of patients who have food insecurity. So this is a national bill. Next slide. Now, the New Jersey Food Democracy Collaborative, we talked a little bit about bringing the expertise of various stakeholders together. So this is something called a Food Policy Council, and a Food Policy Council basically is very closely examining a food system and figuring out where are the strengths, where are the weaknesses, how do we create equity in the food system? And so they do have opportunities for legislation, and I've actually put an example of A 2762, which is a current bill that is to be, as you can see in the small print, the Food Desert Elimination Act. And so Josh is now tracking this bill. So this is just an example of collaborations that can happen. Again, we've discussed this with our specialty society, the New Jersey ACC, and they are also looking at potential advocacy in this space. And we're also talking about various opportunities for education such as this one. Next slide. So, so now I think we really want people's comments at this time. Dr. Chercheo, the leader of our New Jersey and Medical Society New Jersey Climate Task Force, is saying that American College of American College of Physicians can come into this as well. So one thing is, like, how do we, what do we see as our barriers? What do we see as our strengths in terms of getting involved in the equity space? I think that remembering that when we get into these organizations, we have great mentors. I actually, Dr. Chercheo gave me some advice. I said, how did you make space in your busy career to have your organization give you time to do the amazing climate work you're doing? So getting some advice there. But in terms of some policy considerations, education on plant-forward diet, and also the equity considerations. So some of the things we touched on today, and my presentation has kind of touched on them very briefly from the equity side, and then education on the diet impact on climate and how that is affecting equity. or, you know, further discernment around legislative advocacy, or just in general, what are some of the action plans or policy plans that we can talk about in this space?
Thank you, Dr. Ostfeld. Your data were really compelling. And Dr. Robbins, thanks for providing the additional insights. There will be practical suggestions, one of them being to advertise plan forward cookbooks on the website of the Medical Society. Sounds very easy, just needs to be done. All right. I'm willing to entertain any other suggestions. So please raise your hand and we'll call you up. Dr. Saseo has joined us. Thank you. You were responsible for creating this session, and I appreciate your help in setting it up.
Oh, I appreciate your support. I think that this was a wonderful and very informative session. Dr. Ostfeld, I had the opportunity to hear you earlier, and certainly I learned something every time you present. And Dr. Robbins, it was excellent. I actually have a question for each of you. First, for Dr. Ostfeld, the inpatient plant-based diet that was launched, you had alluded to educational materials, and I'm wondering how you got patients on the inpatient side when you're not counseling them directly to adopt a plant-based diet. And my question for Dr. Robbins is if she can talk about the CHA fellowship that she did in Harvard, and her plant-based initiative or her dietary initiative.
Well, thank you. And so it's a bit of a mixed bag with it, because there's so many different physicians caring for people throughout the Bronx, the Montefiore system. It's hard for me to have follow-up on these patients in terms of how much they do or do not adopt the plant-based diet long-term. One thing to know is in the American Journal of Lifestyle Medicine, the health and hospital systems, which has a more resource program than I do, they reported a 90 to 95% satisfaction rate with their inpatient meals, and may have a little bit better long-term data than I do. But what we do is, you know, we have the plant-based meals that you can order for inpatients. Now you can order whatever you want. And that was one of the ways I was able to get it over the finish line to not make it, quote, mandatory. But people who ordered are encouraged just to say something simple. You know, we're ordering healthful foods with fruits and vegetables to help protect your heart. And that they can consult the RDs, the nutritionists, to help to reinforce this dietary pattern. They can put on forks over knives to outsource some of the education for it. And then anecdotally, you know, obviously we look at it as a teachable moment, and anecdotally, some patients have made meaningful changes, but I wish, and I'm under-resourced, I don't have the ability to really tell you in any rigorous way what kind of long-term impact it has, which is a real weakness.
That's very helpful. I think you had mentioned some videos as well.
Well, right, Forks Over Knives plays on continuous loop on one of the inpatient TV channels. Like you could watch CBS or NBC, but also Forks Over Knives plays on continuous loop.
Oh, that's great.
With Spanish subtitles, which is important for our patient population. And I suspect if some of your hospitals were interested, they were very generous and they gave it to us at no cost. I can't speak if they would do that long-term for everybody, but I do believe that they would be open to that if other hospital systems were interested.
Okay, speaking to as a member of Clinicians for Climate Action New Jersey, I learned about a climate fellowship, the Climate Health Organizing Fellowship, and that gave me some community organizing skills and helped me understand the importance of bringing people together. And the project that we had, which was a collaboration with a hospitalist at Robert Wood, and also a nursing doctorate in the community, was that it was about food waste, It was about the methane production from food. There again, you know, a lot of these pieces come together because you know, plant waste is definitely more compostable. And when we throw food out, of course, that exacerbates food insecurity. And that's actually how I learned about the Food Democracy Collaborative. So just there's a lot of intersections there.
Dr. Like.
Yes, good evening, and thanks so much for two really excellent and informative presentations. I have three thoughts and questions, both for Dr. Ostfeld and Dr. Robbins, but also for MSNJ. The first relates to the possibility of developing partnerships between MSNJ and professional organizations and groups like Instacart, as well as Rite Aid, which I understand are beginning to develop partnerships with hospitals around medically tailored meals, produce prescriptions, and things of that sort. And I wonder whether any of these private sector groups might be interested in supporting educational programs or service delivery initiatives that could bring, you know, our practice settings together. As a point of disclosure, my wife actually and I periodically do Instacart shopping during our retirement years. And so we get to find out that there are a lot of people who can't get out to shop for themselves, or they don't live in areas where they can find the healthy food. So that's one suggestion. The second is your thoughts on how we can bring nutritionists and dietitians as parts of interdisciplinary teams working together with us in practice, because how do we learn about these sort of issues if we haven't learned about them in medical school or residency programs? And then the third is, what can MSNJ and others do to further incentivize training around culinary medicine, food as medicine, within our different allopathic and osteopathic medical schools in our residency training programs? I know years back at Robert Wood Johnson Med School, some of the people who were teaching GI metabolism partnered with patient-centered medicine course to teach culinary medicine, and nutritionists would work with medical students, teaching them how to prepare meals. And it actually was a lot of fun, and it was another way of really making the basic science and the clinical science come alive. So three broad areas. Any thoughts on that?
I have a few thoughts. They're tangentially related, and I apologize, I may not address all of them. Those are great themes. The American College of Lifestyle Medicine does a lot of work in this space. And I'm a member, I'm not on the leadership board, but I'm sure that they would be interested in collaborating. They have a lot of experience in doing exactly the types of things that you're talking about to amplify the plant-forward or plant-based message across private and non-private sectors. So I suspect that there could be a connection there. And if people are interested afterward, I'd be happy to connect them with the leadership there, who I'm sure would be interested. And they offer, you know, like a 5-hour CME course. At least they had been offering it for free for medical systems, the American College of Lifestyle Medicine, teaching all about the pillars of lifestyle medicine, which is very much aligned with plant-based nutrition. And of course, Venn diagrams overlap with that and environmental aspects of it. So that's one option. The Gaples Institute, run by Stephen DeVries, he's a wonderful cardiologist who does incredible work with plant-based nutrition. And he has developed a medical school curriculum, which I personally know him. I haven't seen the curriculum, but it's used in one of the Harvard Med School programs, Hopkins, 3 other programs. I'm not sure which ones, but I believe that is available for free, that medical schools can incorporate to teach more about this in a not just like a one-off lecture way, but in an organized, thoughtful way. And my understanding is it's excellent. He's the author of the paper where they queried like 900 cardiologists, and 90% of them said nutrition's important, but 5% of them said we know what to do with it. So that I think would be helpful. You guys offering CME for related talks and things like that could be an incentivization to get people to learn about it, obviously. One simple thing that we did is I had our fellows, I make our fellows put in their progress notes for consults on the inpatient setting, does the patient consume 5 servings of fruits and vegetables a day? Yes, no, deferred. And obviously, if someone's intubated, they can't ask about it. But so, and I put that right above assessment and plan, so it's good real estate. And I do that to drill it into the fellows' heads that, this is all guideline line, like it's nothing that it's important. The patient knows it's important. Anyone who reads the cardiologist note knows that cardiology thinks it's important. And then, people graduate and they go off in other places, and hopefully it sinks in. So those are some thoughts, quick ones off the top of my head.
So yeah, so I think that is a great direction. I have been researching the College of Lifestyle Medicine, and I've been interested in their shared medical visit model, because as you alluded to, a lot of times, especially social isolation is big, and people engage in health behaviors when they have programs that connect them. So what I would like to see is a program offered by ACLM that really unpacks for us, like, what can we expect to learn in the 5-hour free program that they're offering our FQHCs. Because I think we kind of need to understand the content, because even though it's a free program, and that's amazing, our FQHC staff are out fishing people out from under the boardwalk, and we need to kind of have an idea what we're committing ourselves to. So I think that kind of sense of what, how I know that they have a big equity program, and kind of unpacking exactly what they have to offer, like the Cliff Notes version, would be like a great education in my mind.
Dr. Wang, you're another member of the Climate Health Task Force headed by Dr. Cecile. Please offer your comments. It would help if you unmute yourself.
Sorry about that. Thank you for a very inspiring and much needed talk. I'm a lifestyle medicine internist and geriatrician. And when I see patients who have been discharged from the hospital post-MI and counsel them on a whole food plant-based diet, I'm mournful when the patients tell me that they continue to eat animal-based foods and processed foods because that was what the hospital gave them during their post-MI stay. So I think it's great that Montefiore has an inpatient plant-based program. And so my one question I have for Dr. Ostfeld is that, do you envision that all in the future that all hospitals in the U.S. could have an inpatient plant-based program? And then a broader question for MSNJ is that, would MSNJ have a role in facilitating NJ hospitals' adoption of inpatient plant-based nutrition programs?
I think that there are certain states that now have laws that you have to have a plant-based meal option, like a vegan meal option. California has that law. We started a program before New York developed the law, but New York now has a law. So it's like some of these states, you have to have it. It doesn't mean you have to use it, but you have to at least offer. And I do think that it's so aligned with any kind of guideline. I do think that that will happen across the US over time. Now, getting people to use it, getting people to eat that way is another issue altogether. And really the model program is the health and hospital system in New York City. Montefiore is not a part of that. Bellevue is kind of Bellevue, Jacoby is kind of their flagships. But they've done it quite well there. I mean, and it's spearheaded by the mayor, and of course many physicians and other people involved with that as well. So I think that's kind of the role model program.
Dr. Cecile.
Yes, sorry, I had one other question. I'm sorry that I didn't ask it sooner. As we were talking about the education component to this, I dropped in a link on the Summit for Medical Education and Nutrition from ACGME. There's another link that I'm just putting in here right now on a proposed nutritional competency framework. But I wonder for both MSNJ and also potentially at the AMA level, if there's opportunities to extend more medical education in this field, both to faculty who then have to train our students and our residents, but also for our medical students, something MSNJ could support, or if there would be interest in it.
I think these are great suggestions. I happen to be friendly with the dean of both the Rutgers Medical Schools and that of the Hackensack Meridian Medical School, and I'd be willing to draft a letter and politely inquire where they stand on the provision of such training programs. Dr. Like, you have your hand up. Please unmute yourself.
You're muted.
Apologies. I had meant to ask Josh this question before. You had mentioned at one of our JEDI task force meetings that someone from the New Jersey Department of Agriculture was interested in learning what physicians in New Jersey thought about a variety of nutritional issues and reported to the governor. Is there anything more you can say about that potential initiative?
Yeah, so that collaboration is something that we're pursuing likely for the end of 2024. I think the information that we learned from this talk will be incredibly helpful as we go back to work with the Department of Agriculture. And actually that task force that individual works with was actually appointed by the governor. So there's definitely a wellspring of interest at I would say the highest levels of government in moving the needle on this. But yeah, I think that's the next step after this PSP.
Thank you, Mr. Bengal. I think we've reached the end of this program. We have taped this program, and I've taken notes, and many of you will also, and we will consider some of these notes at our executive committee. Having said that, I thank you all, particularly Drs. Ostfeld and Dr. Robbins, as well as Dr. Ceseo, who helped me set up this program. I had additional help from Dr. Henry Dindial and a constant encouragement from our president, Dr. Sui. I thank you all and good night.
Thank you.